So thank you very much, Mark. And I'm deeply honored to be here and to deliver this talk as a presidential lecture of ISDE 2018. I'd like to take this opportunity to express my thanks to all of those contributed to this special event and all of the audience gathered here. Thank you very much. So today's my talk is Controversies in Esophagology, East and West, Esophagus and Stomach. I have some COI to disclose. ISDE was founded in 1979. Inaugurate society president was Professor Kome Nakayama, who is a giant in the history of Japanese surgery. In 1960s, he conducted esophagectomy with very low mortality rate, less than 5%, which is almost same as current average rate in Japan. So I'm very honored to serve as third society president from Japan, following Professor Nakayama and Professor Inoguchi. They are so big names in Japanese surgery. And this is my first participation for ISDE. Actually, this is the first time to present some data in international congress. It was held in Kyoto, organized by Professor Nabeya. And in that congress, I presented significance of obesity and accumulation of the abdominal fat for the post-operative complication. In that presentation, I have found that low body weight patient with poor nutrition also has a serious complication. That was a sarcopenia in current concept, but I didn't realize that. Anyway, so the next one in Japan was 12th ISDE Congress held in Kagoshima, organized by Professor Aiko. And this is the first time for Japanese surgeons, but this is the first time to organize it outside of Japan. So I'm very happy to have this meeting in this beautiful and historical city, Vienna. As shown in this slide, esophageal squamous cancer is predominant in the East, more than 90%, including Japan. And in the West, of course, adeno is predominant. Now, which is on the rise still. This is the same trend in female. So, therefore, it is very difficult for us to introduce the evidence obtained in the other side. Regarding my own experience as a chairman of the guideline publication, it was very difficult to decide on how to use the evidence from the West side, mainly focused on adeno. So there are so many controversies in upper GI oncology. So shall we change the treatment regimen between squamous and adeno, and which is better, neoadjuvant chemo or perioperative chemo? How about the significance of radiation? And then what is the best or optimal surgical approach, and so on. So today I'm going to talk about direction of multimodal treatment for esophageal cancer first. So I'm chair of the esophageal group of JCOG, as shown in this slide. And then I'd like to show some data, and then I indicate red. So from JCOG, or our own study, and then blue is kind of reference from the outside. In 1980s, three-field intensive lymph node dissection has been developed in Japan. And although there is no solid evidence based on the large-scale randomized controlled trial, we believe that we can significantly improve the local control in upper mediastinal area, which is a frequent site of lymph node metastasis from squamous. So accordingly, in Japan, so if you look at the survival data of a clinical trial of surgery alone, Japanese data is better, and consequently, in the West, from 1990s, the physicians introduced neoadjuvant chemoradiation as a standard care. So our Japanese just compared the very intensive surgery and surgery followed by chemotherapy first. And then we found that post-operative chemo contribute better survival, better 5-year disease-free survival, in particular for the patient with node positive. And the next, we compared the surgery, neoadjuvant plus surgery, and post-operative chemotherapy in JCOG 9907, which is the most important study to decide the current standard in Japan. As you can see here, neoadjuvant chemo followed by surgery, very intensive surgery, is the current standard in Japan. If you look at the data of subgroup analysis here, survival benefit for stage 3 patient is not satisfactory, and then therefore we need more powerful neoadjuvant treatment. If you look at the data from the West, this is a famous cross-trial from Dutch group. They compared surgery alone again and chemoradiation neoadjuvant therapy using carboplatin and paclitaxel. As many of you know the results, neoadjuvant chemoradiation therapy are better than surgery alone. It's natural, but it is surprisingly the impact, survival impact in squamous is much better than adeno. And almost half of the patients showed pathological complete response. That has a great impact for our Eastern physicians. So we are dealing with squamous. So maybe we have to think about to introduce chemoradiation as a neoadjuvant setting. Accordingly, now JCOG 1109 is being conducted. This is 3-arm comparison between standard chemo with 5-cisplatin and intensive DCF triplet treatment and Western-style chemoradiation therapy. So we don't know the result. But if chemoradiation therapy found to be better, so we have to change our standard treatment. And then maybe Western physicians will say, oh, you are 30 years behind us. So realize finally. And then if DCF arm found to be better, so it will confirm the Japanese style trend combination with intensive chemo and intensive surgery makes sense. I don't know the result, but result is really anticipated. And the attention, much attention has been received from across the world. Microphone is okay? Okay. So if you look at, it's on, it's on. In NEORES trial, yes, conducted in Scandinavian countries. So even in Europe, Western countries, there is not solid evidence of comparison between chemo and chemoradiation as neoadjuvant treatment. Of course, surgery alone is no longer standard treatment anymore. So they compared chemo versus chemoradiation. And then neoadjuvant chemoradiation showed a higher rate of complete response. However, survival curve was totally overlapped. And then they reported that there is high incidence of anastomotic leakage and then higher rate of the death and cause of other than tumor recurrence in the chemoradiation group. So there are several evidence. This is meta-analysis. The post-operative non-surgical and surgical complications is the factor for poor prognosis. Strong neoadjuvant treatment is not always improve survival. This is very important. This is a sub-analysis for JCOG 9907. We just focus on neoadjuvant chemo group. Understandably, all these patients received neoadjuvant chemo, but the patient with serious pneumonia showed poor survival than without pneumonia. So something happened by post-operative complication. So there are two stories. Intensive perioperative treatment. Preoperative treatment induce good response and good survival. On the other hand, is the cause of the serious complication may lead the cancer metastasis or recurrence. So we have to think about the balance of the two factors. So, esophageal complication consensus group was established by Professor Donlow, and this is very important activity, which is a basic for the next ESO data, which might contribute our next AGCC or our shared database for all over the world. Anyway, the data from ECCG showed the complication rate in high volume centers in the world. Look at this. Almost 60% of the patients showed complication, even in high volume centers in the world. So now we have to pay attention for complication. Nowadays, minimally invasive esophagectomy has become much more common in the world, but the point is this type of the minimally invasive procedure can reduce the complication rate after surgery or not. One little bit small but very important randomized control trial was reported from Dutch group. They compared the pulmonary infection rate between open versus minimally invasive, and they showed that reduced pulmonary complication rate. Now, JCOG is conducting this randomized control trial between open versus minimally invasive, and then primary endpoint is overall survival. But there is some chance to achieve this endpoint or even superior, because minimally invasive surgery has some potential to reduce pulmonary complication, which is most important serious complication after surgery. So another very interesting topic in Japan is transmediastinal endoscopic surgery. So in this case, you don't have to open the chest. This is a procedure I have done for cadaver using Da Vinci Xi system. So you can put a very small incision on the neck and introduce the port from the neck, and then you can perform lymph node dissection along recurrent laryngeal nerve like this. This procedure is still under investigation, but I assume that there are several types of robotic system is coming, and then they are available. If they are available, it's going to be helpful to realize this type of the new surgery to reduce complication rate. And then imaging technique is very important. 3D endoscopy and also 4K, even 8K. This is a 8K system. In the future, this type of new technology allows us to improve the quality of surgery. Next, let me just talk about roles of the surgeons in the new era of multimodal treatment for esophageal cancer. So, by the highly advanced technique of endoscopic treatment, you may see this morning session. Superficial esophageal cancer limited in the mucosal layer can be dissected regardless of the size. It's amazing. But it wants to invade to a borderline area between mucosa and submucosa. You have to pay attention for micrometastasis. The JCOC endoscopy group, led by Professor Muto, conducted this very interesting trial. They resect the superficial T1B esophageal cancer by endoscopy. And then they add some radiation therapy, chemoradiation therapy based on the pathological findings. The result was very good, acceptable, and that means, in generally speaking, in early stage esophageal cancer, the role of surgeon tend to be limited. How about the advanced case? So definitive chemoradiation is a very unique non-surgery strategy. You cannot apply this one basically for gastric cancer. We have conducted phase 2 trial using a definitive chemoradiation using LTOG regimen, and then we enrolled the patient with stage 2 and 3 potential resectable, but who does not want to undergo surgery as initial treatment. But point of this study is we perform salvage endoscopic treatment and surgery as soon as residual disease and recurrence were detected. This is very important. Kind of optimal multimodal approach for advanced esophageal cancer. What about the result? The result was reported in ASCO 2018, very recently. 3-year overall survival was 74, and esophagectomy-free 3-year overall survival was 63. So this is another option for advanced esophageal cancer, resectable esophageal cancer. So in the future, we have to compare the surgery-based treatment and the non-surgery-based treatment for this patient group. If you look at the trend in the West, SANO trial is ongoing following cross-trial. They are comparing cross-regimen and very careful active surveillance, exploring some definitive chemoradiation for this patient group. So in either case, our surgeon has to do surgery after chemoradiation or some very intensive chemo. How about unresectable advanced esophageal cancer? This is not the target for surgeons. However, we conduct very small Cosmos trial and reported the data in British Journal of Cancer. We performed DCF induction chemo instead of conventional chemoradiation for these borderline and unresectable patients, and then surprisingly, almost 40% of patients converted to resectable by initial DCF induction chemo. And then data for survival is very, very good as an initially unresectable advanced esophageal cancer. So now, in JCOC, we just started this study comparing conventional chemoradiation or induction chemo for this advanced stage. So, immunocheck inhibitors. This is one of the hot topics in the various types of tumors. This is almost, biggest topic in ASCO, ESMO kind of medical societies. So this is a study design of the efficacy and safety of immune checkpoint inhibitors in patients with esophageal cancer who are refractory for the standard treatment. We published the data in Lancet Oncology last year. Response rate was limited, just 17%, but long-lasting, very good response was observed in responders. So now JCOC is planning to start the neoadjuvant IO immunocheckpoint combined with chemo as a neoadjuvant setting as a phase 1. This is very challenging because there are serious complications, serious immune-related adverse events have been reported. In case of a very invasive esophagectomy, if you see some very serious immune-related pneumonia, it's going to be fatal. So I like to say that the surgeon must be very powerful and skillful and then brave, because you have to do surgery after chemoradiation or intensive chemo, even after immunotherapy. And then you have to be very skillful to do an R0 resection without any serious complication. And also we have to pay attention for serious, very complicated adverse effect. So using illustration of skin, the surgeon in the future require not only the skill to slide down well-maintained, very smooth slope, but also you have to survive in this kind of very difficult situation, or you have to have a very strong inner strength, right? So this is the future of our surgeon. So prevalence of the GERD symptom in the East is lower than the West, but it's gradually increasing in Asian countries because aging will affect the esophageal clearance, and then reduced rate of Helicobacter pylori will increase the acid in the stomach, and increase BMI by changed dietary habit will increase the inner abdominal pressure and frequency of transient LES relaxation. Due to this trend, the incidence of adenocarcinoma is gradually increasing even in Asian countries. So what is the optimal treatment for EG junction cancer? This is a very important topic. I just picked up this topic for many sessions in this Congress. So MAGIC trial is a very famous standard perioperative chemo for gastric and EG junction cancer. You know very well about this data. And now FROT4 regimen is determined as a new standard. The FROT regimen found to be better than MAGIC regimen was reported in ESMO in 2017. As I mentioned before, cross-trial regimen is much better in squamous and then still have survival benefits for adeno, but nobody knows what is the best optimal treatment on the EG junction just for adeno. Maybe you will take the FROT4 for gastric cancer and then cross for squamous esophageal cancer, but this is very important to decide what is the standard, the treatment for EG junction adeno. So the result will be anticipated. So there are so many studies ongoing or already reported as for the squamous or adenocarcinoma of esophagus, EG junction, and gastric cancer. Tomorrow morning, we will have a plenary session for pivotal studies for these with Professor Ferguson. So maybe the result of these studies will tell us the direction of the optimal multimodal treatment for EG junction cancer. So as you know, the molecular-based, genomic-based precision medicine is already accepted in the world, and then now maybe global standard guidelines based on molecular information, genetic information might be feasible, and then it's no longer just a dream. So maybe we can discuss this issue intensively in the next ISDE meeting. So what about the role of the EG junction cancer? What about the role of surgeons for the treatment of EG junction cancer? There are two major players, general thoracic surgeons and GI surgeons. In this area, they have different habit and different way of thinking, so that we cannot use the retrospective data accumulated in this setting. So, Zebra type 1, type 3, there are some very solid consensus, but we didn't reach to the consensus for Zebra type 2 or EG junction cancer classified by Nishi's classification. To approach this issue, Japan Gastric Cancer Association and JES Japan Esophageal Society made a collaboration working group to do a prospective study to know the real distribution of the lymph node metastasis. Clinical T2 to T4 cancer, EG junction cancer classified by Nishi's classification, enrolled in this study. And in squamous, we performed right transthoracic esophagectomy with very intensive mediastinum, abdominal, para-aortic lymph node dissection. And we performed the case with adeno. Esophageal invasion was less than 3 centimeters, and also there is no node positive imaging before surgery in mediastinal area. We performed lower esophagectomy by transhiatal approach. And the patient has esophageal invasion more than 3 centimeters or positive node by preoperative diagnostic imaging, underwent just esophagectomy, the same surgery for squamous cell cancer. This is a multi-institutional single-arm prospective study to explore the distribution and the metastatic rate in this patient population. This is the results. The rate of lymph node metastasis in abdominal area, upper, middle, and lower mediastinal area were as expected, almost. But rate of para-aortic lymph node metastasis was relatively low, only limited for far advanced cases. Maybe we don't have to do a prophylactic para-aortic lymph node dissection for this patient group. But this data is very interesting and contrary to our expectation. There is only little difference between adeno and squamous in terms of metastatic rate in mediastinal area. This is the data for upper mediastinal, middle mediastinal. This is the data for lower mediastinal. The same. There is very little difference between adeno and squamous. What is the most important factor to decide approach or extent of the lymph node dissection in this series? That was the length of esophageal invasion, as you can see here. The location of the epicenter of a tumor does not tell you anything. So this is another very important data provided by Professor Doki. In this series, we saw very high anastomotic leakage rate, almost same as esophageal surgery. What's happened? What's going on? The case reported as Crabian Dindo 4 or 5 are all cases with transhiatal approach. Reconstruction has made in lower mediastinal area. Once something happened, it is very dangerous. You have to be very careful about reconstruction in the lower mediastinal area. This is very important information for our surgeons. This is the data from Cancer Institute Hospital. They recommended 2 centimeter proximal margin, which is very important to keep the good prognosis. 2 centimeter. So from these data, from this observation, we just proposed this algorithm for the surgical approach for age junction cancer. This is just draft, not fixed yet. First of all, we don't have to separate approach by histologic type. This is very important new message. And then we have to decide approach by esophageal invasion. If invasion is more than 4 centimeter, you have to do an esophageal surgery, just same as esophageal cancer. Less than 2 centimeter, you can apply trans-hiatal approach. As you already noticed that, it is very difficult to measure the esophageal invasion accurately, so that there is some borderline area. So in this area, the surgeon has to make a critical decision by their experience, their skill, or the condition of their patient, or biological behavior of the cancer based on molecular or genetic information. The surgeon has a very important role in the multimodal treatment in age junction cancer. Let me go back to the history of the ISDE. First inaugural Congress was held in Tokyo, Japan. The topic, most of the topic discussed in the conference was squamous esophageal cancer, as you expected, which is predominant in Eastern Asian country. As symbolized the first logo of ISDE, which featuring Mount Fuji. The initial phase of ISDE was strongly supported and operated by Japanese surgeons. Professor Siebelt, who is very famous as his classification on adenocarcinoma on age junction, hosted Third International Congress in Munich in 1986. At that time, he just organized Western esophageal study group, all scattered in the European area, and then brought them together under ISDE. It was a very important movement. Oh, he looks a little younger than he is now. Meanwhile, Professor Mark Ferguson, who served as 11th president, and now he is leading this society as executive director. He, in 2004, as I remember, and he proposed and he made advocate in the shift of policy to promote the participation of gastroenterologists, physicians, who can handle with benign diseases, which is much more common in Western world. That was very important movement again. In response, the main office, headquarter office of ISDE in Tokyo was taken from the surgeon's hand to a Japanese surgeon's hand to Western world. It's moved to Los Angeles under the leadership of the Professor Tom Demister, who is a well-known great surgeon for esophageal or gastric area. At that time, the logo of ISDE changed from Mount Fuji to the map of the world. So now, ISDE became a true, real international society, that kind of reborn. However, there was some limitation in our society now. So if you look at the membership, still active membership is steady, not significantly increased. And also there is lack of diversity in gender and professional. So many male surgeons in our society. Fortunately, in this Congress and then previously, World Regional Esophageal Society actively supporting us by forming joint sessions such as ESD, CSD, and JS. ESD and CSD is already their affiliated society of ISDE. And this time, we officially invite IGCA, International Gastric Cancer Association, to just discuss about topics on EG junction. So we should be connected through EG junction. We should be one singular organ, not separate organs, right? This is my dream. So now, moving forward, our ISDE has to grow beyond border of country and beyond barriers of specialties. So finally, I'd like to thank Dr. Hiroko Ide. She is an officer for ISDE for many years, and she is still an active leader in Japan branch. And this is the office of Kome Nakayama, still existing in Tokyo Women's College. And also, this is Professor Nobutoshi Ando, who is a mentor, my mentor of esophageal surgery, and then also he is a former officer of ISDE. They provide me very valuable materials about history of ISDE. Maybe we can use it for the next meeting for the 40th anniversary of ISDE. Of course, I'd like to express my sincere, cordial appreciation for these members. Professor Mark Ferguson, Executive Director and leader, real leader of our society, and Professor Pratik Sharma is Vice President. Now he's going to be a President the next meeting and next 2 years. And then co-chairs of the program committee, Professor Pramesh, and then Professor Muto here. And then also I'd like to thank all local organizing committee members. So chair was Professor Shopman. Also, I'd like to thank all these members from JS, JCOG, IGCA, and upper GI team of K University, providing me a very practical support for this talk. This is my final slide. I'd like to conclude in some words. I express my dream, I hope. ISDE becomes the bridge links between West and East in the research of esophageal diseases, and also as well as a platform, international platform for the upper GI disease from esophagus to stomach as only one singular organ, not separatedly, connected by EG junction. Thank you very much for your kind attention.